Good afternoon, everyone, and welcome to the New York Society of Interventional Pain Physicians Business Essentials during the COVID-19 pandemic. The conference call will begin in just 2 minutes. Thank you so much for joining us this afternoon. Good afternoon, everyone, and thank you for joining the New York Society of Interventional Pain Physicians webinar, Business Essentials during the COVID-19 pandemic. This conference call will begin in just 1 moment. Thank you so much for joining us. Good afternoon, everyone, and thank you for joining the New York Society of Interventional Pain Physicians seminars, Business Essentials during the COVID-19 pandemic. Sponsored by Doctor.com. I would like to introduce the agenda for the call today. As you can see, we have 2 fantastic panels that will be presenting to you. I would like to introduce the moderator for the session, Dr. Sudhir Dewan. Dr. Dewan is the president of Advanced Spine on Park Avenue, executive director of the New York Society of Interventional Pain Physicians, and the chairman of the annual New York, New Jersey Pain Symposium. Dr. Dewan, thank you for leading this call.
Hello, everybody. Thank you, Michelle, for the introduction. And I would like to welcome all the listeners for this afternoon second webinar hosted by NYSIPP. This is a very good webinar put forward for address those 2 very important questions that we have. One is about the telemedicine, and second is about the CARES Act and the accelerated advance payment program of the Medicare. So we are here for an hour and a half time here, and looking forward to everybody's participation and questions. And I'll take this opportunity to introduce the first speaker. Our first speaker is Dr. Edward Rubin. Dr. Rubin is our immediate past president of NYSIPP. He has a very busy pain practice in Long Island. He's a very important and very respected, renowned member of our community, and he is very knowledgeable in this telemedicine issues. So here, Dr. Rubin, to talk about telemedicine.
Thank you, Dr. Dewan. I appreciate that. So we're going to touch on some fundamentals first, more on the billing side of things. So we can go to the next slide, please. So it's been a very common question as far as what is the proper way to bill your telemedicine visit. The consensus right now is if you're using a live audio and video connection, that you can bill a 99213 or a 99214 along with a place of service code 2 and potentially a 95 modifier. That's essentially the same E&Ms you're using for the office. My advice to you is that you put in your notes that you also did have live video and audio, and we'll get to some other ways to bill if you're unable to do it that way. There has been some debate on the modifiers in the place of service. Not every payer is the same, and we're trying to accumulate some information as far as which payers we know will pay at regular office rates. If for some reason you're not able to get the patient on to a live video situation because They just don't have the technology. There are codes for billing based on your time for the telephone portion of it. There's some discussions that Medicare may pay for a telephone only, but I would be cautious about that. These codes are really meant to be for live video and live audio. The normal deductibles apply. There's also a lot of things going online saying that patients don't have to pay copays with telemedicine. That may be true for COVID specific related services, but in my opinion, my understanding of reading the documentation, patients would still pay their normal copay. We have been assured by at least CMS that they're not auditing right now as far as, where the patient is, where you are. The traditional model was, the patient had to be in a rural area, but that's no longer an issue. That's all been waived through at least June. Have the next slide, please. All right, so basically you're going to document just like you would in your regular note. Obviously, you need to be careful about how much you're putting on exam. I think Dr. Garibo is going to talk on some ways you can beef that up in a little bit. Again, the expectation is that you have live video and audio. Like I said before, there was some things posted that until June 6th, you could do audio only. I mean, based on what my understanding is, that I would be careful with that. If you're doing just telephone, you can bill a 99422. Obviously, that's not going to pay as much as a regular office visit. I personally have been in the habit of telling patients that what we're doing is a billable encounter. I think it's just polite to mention to them that you are billing for this. Some may not realize or think it's just kind of on the house when the doctor calls you at home kind of thing. So as a courtesy, I like to let the patients know so they don't take it as some sort of surprise medical bill when we bill it. Next slide. There was a slide about specific payers, but what I've gathered, the only ones that I've seen that are really pushing back, at least up until a couple weeks ago, was Cigna and MagnaCare. The rest of the payers seem to have gotten on board with doing this. You can look into each payer specifically. I think as a society, we're going to try and see if we can get that information together and get that out. But I would like to say the take home here is get live audio video, and 99213, 99214 with the 95 modifier should have you covered for this. And I'm going to turn it over to Dr. Garibo.
I would like to introduce here the next speaker, Dr. Garibo. You all might know Dr. Garibo is pretty well known in our area here. He's a professor of anesthesiology and pain medicine at NYU. He is a past president of NYSIPP, and he has enormously contributed in literature and all conferences by speaking, and he's a very important faculty in our seminar, our webinar today. Dr. Garibo, please take over.
Welcome, everybody, and it's a pleasure to have so many of you here. I believe that once the COVID crisis is over, we're going to stabilize at a new normal, and we're going to benefit from many of the practices that are currently in place specific to COVID. A good part of that is telemedicine, and it's going to be something that we can be using going forward to grow our practice, to screen our patients for appropriateness for our practice, and use it to market more effectively across our region, outside our state borders, and truly potentially outside across the country as well. This is a tool that is here to stay. This is a tool that we need to implement effectively, both for documentation purposes and for follow-up purposes during pandemics such as COVID-19, and for future practice growth. Now, for this to happen, Dr. Rubin already went over some of the essentials of it, but it's something that we need to get people on board with from a technological perspective, from a minimum requirement perspective, from EMR documentation perspective. So, for example, for those of you that are using Epic, there are some essentials that need to be in place, such as, for example, signing on to MyChart, having that up to date, having a hardware that is compatible with telemedicine, a secure, fast internet connection, all are essential elements that a patient needs to have on their end. And what I would recommend here is that as the patients are calling you to have a simple chat, encourage them to go on to telemedicine. Tell them that you're going to communicate with them through telemedicine at this time of crisis. It's not advised for them to come to the office and so on and so forth. And the best way to talk to me is through telemedicine. So take advantage of the next 4 to 6 weeks or so. As you go about doing your weekly schedule that is COVID-19 specific, that's something that may translate into something more telemedicine friendly going forward after the national emergency ends. Set up block times within your schedule for telemedicine versus in-person visits, and set up a quiet, private, presentable space for you to be able to telemedicine with your patients. What we've done at my institution is 30 minutes for new patients, 20 minutes for follow-ups, and of course that's something that's going to determine your billing as well. And furthermore, what we're discovering is that during telemedicine visits, it's really a higher standard of care, a higher degree of communication with the patient that I believe will allow us to understand the patient better, understand them, understand their condition, be able to perform some degree of physical exam. What many of us are finding out is really a superior way to interact with our patients than a telephone encounter. Next slide. So what we're finding is that there are a variety of different ways to use telemedicine, and one of them that is going to be more lasting than the COVID-19 crisis is to use it as a screener for our new patients, to gauge the patient's appropriateness or inappropriateness for our practice, evaluate the patient for a specific procedure that they're calling you or coming to your practice for that nobody else offers. They may be coming from out of state, from a distance, potentially identify drug seekers, legitimate patients that you can help versus patients that you can screen out that you probably have not much to offer to in terms of the treatment. Screen vulnerable patients and sick patients. These COVID positive patients are going to be around for many months to come, maybe even over a year. Ask them to stay home if they're sick, screen them for acute illness, identify the vulnerable patients, advise them to follow with their primary doctor for their flu-like symptoms. This way you're protecting yourself as well as your staff. You can still consider office visits and in-person visits for any patient that is requiring significant adjustments that are chronic opioid therapy, anybody that is at a level of care, at a level of, let's say, chronic opioid therapy above and beyond the CDC guidelines in terms of their opioid prescriptions. So through telemedicine, we can address treatment gaps, such as happening during COVID-19, potential allegations of abandonment, and provide a relatively comparable level of care and use it to grow our practices, as Jessica is going to talk to us about shortly. As far as your history, this is a typical E&M. You've got to have a history, physical exam, review of systems, assessment, and plan. Location, intensity, directionality of the pain, and during the history, bring in the verbal and the nonverbal cues to show that you're listening. Do nod, do gesture, do understand the pain, have the patient point to their area of pain, where they may be having the pain radiate down the arm and so on. And that's very helpful in terms of physical exam documentation. So this is where you can look at the injection site, take a look at for autonomic symptoms and signs, evaluate the patient's ear, nose, and throat, evaluate the respiratory system, their mental status, the injection site, their ability to get out of chair and walk around and demonstrate to you where their pain is, where it's originating from, and what it is radiating to, document their mood status, and document the neurological exam to the extent that it can be assessed. So clearly, this is a new normal. It is something that we're going to be using in our practices going forward, is the probability, and it's going to be something, it's going to be a tool that we can use to expand our practices.
Is this the end of your slides?
Yes.
All right. So the next speaker is Jessica Nixie. She is from doctor.com, and I want to tell our viewers this program is sponsored by doctor.com. So thank you, Jessica, for sponsoring this. Jessica oversees the doctor.com emerging markets group, which specializes in bringing innovation solution to private groups. Thank you, Jessica, for coming on the panel as expert, and you please take over.
Hi, thank you, Dr. Dewan, for that introduction. I am going to dive into the non-clinical aspects of your practice that you can get in order to communicate with and even continue to treat patients during this difficult time and potentially save your business. That brings us right to telemedicine, of course. And even in a time of crisis, people still need care. So the Office for Civil Rights at the Department of Health and Human Services made the decision to relax HIPAA penalties around telemedicine to accommodate this need. Doctors can use everyday non-HIPAA compliant platforms to conduct appointments virtually. I'm talking specifically about platforms like FaceTime, Google Hangouts, Duo, and other technologies. What's more, HIPAA regulations have been loosened across state lines. This is huge. So what I mean by that is that you can treat patients regardless of geography. This is an opportunity for the taking. Patients can see anyone, anywhere, and they're not limited to physicians within driving distance. And with that said, on the next slide, it's about choosing the right technology, right? So just because you can use a non-HIPAA compliant platform doesn't mean you should. And physicians are beginning to realize this, especially with recent security breaches, with Zoom in particular, for example. I've actually been talking to two kinds of physicians out there about this. There are some who just want a simple solution, like a FaceTime. They think this is all going to blow over and they're going to get back to treating patients in their office in a couple months. And then platforms like FaceTime and Google can be problematic. For example, they don't keep your personal phone number or email addresses hidden from patients. And then on the other side of the room, we have physicians who are looking to make a longer term investment in a platform that's more robust and can be used after the COVID-19 pandemic is over. And because they see the value in using telemedicine, they're going to incorporate this now and in the future. So now it might surprise some of you to learn that patients actually like the telemedicine experience. It's been shown to directly correlate with patient satisfaction scores. And 1 out of 5 patients would even pay more to have a virtual appointment instead of an in-office one. I actually agree with the experts who are predicting that once patients get used to telemedicine, they will continue to demand this experience. So why would you take all the time to travel and go into the office if it's not absolutely necessary from the patient's perspective? Now, in the next slide, we'll talk about some best practices to consider while you're on your telemedicine visit. So ideally, you want to create a nice, quiet, private place for patients, use secure, fast internet connections, get patient consent ahead of time, encourage patients to conduct appointments on their mobile devices, and set expectations to help patients prepare for the virtual visit. Use verbal and nonverbal cues to show that you're listening. Okay, and then here in the next slide here, we'll talk about spreading the word about your telemedicine services. So I just briefly want to touch on the different ways you can do this. Third-party sites are really great in terms of adding COVID-related information. I know I'm betting that some of your information has changed over the past few weeks in light of COVID-19. Maybe you've had to postpone non-essential appointments, elective procedures, or even routine checkups until the pandemic is over. Maybe you've updated your waiting room protocols to help your patients better practice social distancing. Whatever it is, many patients are looking for information from you about coronavirus as well as how your practice is addressing it. So you need to make sure that they can easily find that information wherever they're looking for you. Some things to consider are banner ads that you could add on profiles like Healthgrades, which is the #1 site for doctors at over 30 million unique visitors a month, and that redirect patients to special announcements on your site. And you want to also clarify what kinds of visits you're able to take right now and how the patient will be interacting with you, virtually or in person, for example. Make sure you're communicating that information on your website in the form of pop-ups, blogs, adjusted office hours, and anywhere else patients might be looking for that info. And also don't forget to update your voicemail, your email footer, and any other auto reply emails that you have going out to include COVID-19 and telemedicine services. I actually received a text message from my PCP letting me know that it was available, and I thought that was really helpful. Now, in the next slide, we're going to talk about reviews and how you can help differentiate your practice in this new virtual climate. Better yet, use patient reviews to spread the word about your telemedicine services. I often advise my regenerative medicine physicians that can collect, that they should absolutely collect procedure-specific reviews so you get known for the treatments and the therapies you offer. But mainly, you really want to convey what the success rate is, especially for these higher-end treatments, these cash pay treatments. We conducted a survey last year on patient adoption for regenerative medicine, as an example, and one of the biggest barriers was social proof. Second was pricing. So with that said, how can you convey some of your patient outcomes and some of those testimonials on third-party sites and utilize that information to instill confidence in both new patients, referrals, and anyone out there that's looking for alternative treatments or a second or third opinion. So the same goes for telemedicine appointments. Collect reviews right now about the virtual experience to gain buy-in from other patients who may not be convinced that telemedicine is right for them. Because there's definitely a psychology here from the patient and physician perspective in terms of adopting this, trying it for the first time, and then figuring out if this is something they want to use long-term. Plus, this will help you build a solid pipeline of patients for the future and also help you maintain your current patient base, which is very important right now. And until, COVID-19 is over, you want to also make sure that you're ready for the gold rush of patients seeking elective procedures. So are you prepped for this? I know a lot of us have laid off a lot of our employees and whatnot, and we want to make sure that we're ready for anything and we can navigate through this uncertainty with the best strategies possible, so that anything that you try to do right now will help you have the second best half of the year you possibly can. So thank you so much. Oh, sorry, one more slide. I actually added this. So I was talking to Dr. Rubin the other day, and I obviously looked him up right away. And I noticed that on Healthgrades, he had an amazing review. This is something I stress to a lot of my clients. Again, getting procedure-specific reviews, having patients leave details on the review, and obviously having them talk about the telemedicine experience is even better right now. Since everyone's quarantined at home, they have more than enough time to leave you a review. So I'll read out loud Dr. Rubin's most recent review because it's amazing. So I've been a patient of Dr. Rubin's for over a decade. I have been able to get back to work, volunteer in my community, chase after a grandson, and socialize with friends. Now with these challenging times, I was pleasantly surprised with how incredibly easy the telemedicine appointment was, and I totally recommend it. At least until we can all move about freely, Dr. Rubin is always offering the latest therapies from laser treatments to ketamine infusions, which I also highly recommend. His staff are super friendly and professional. That was like the best review you can possibly get, and I highly encourage you focus on getting reviews like that now and in the future.
Thank you, Jessica. This was wonderful. And I'm actually not very surprised to hear this review for Dr. Rubin. Those who know Dr. Rubin will agree with me. He's one of the finest and the best physician we have around. and we are very proud to have him as our colleague. So, but I do have some questions for you. This question is, I think maybe Chris can answer. Did CMS waive requirements to have physical examination?
Yeah, very much. It's standard E&M as if the patient is in the office, and you have to document review systems and physical exam.
Okay. There is another question. This may be for Dr. Rubin. Can we use 99202 or 99203 initial visit if the visit is done via telehealth?
So this is something we had talked about prior to this meeting. The exact language from CMS, there is an expectation that you have an established physician-patient relationship when you're billing for telemedicine. So if you want to go by the guidelines for CMS, directly, then sounds like it shouldn't be used for new patients. Now, given what's going on in the world, I personally have seen a few new patients on telemedicine. So right now they're not auditing these things, but I think in the future when people can come in the office, the expectation is that telemedicine is more appropriate for an established patient. And just quickly on the last question, New York state regulations do not require a physical exam for a refill of opioid. The office visit is required, but you don't have to document a physical exam. New Jersey is different. New Jersey does require a physical exam. So some of these physical exam requirements depend on what state you're in.
So that's quite interesting. But if you have an established patient, then you do have physical examination. But if a new patient and is coming for prescription and you want to help the patient, would you still be able to do it by telemedicine?
I have a couple times because I do a lot of the post-operative management for the surgeons at my hospital, and I have not seen the patient before and they had surgery. I think it's about context. If you're seeing a legitimate patient in a legitimate context, I don't think you're sticking your neck out for that. We could see obviously where this could go and be abused, with people calling up and saying, oh, I just want an opioid script and I live in Texas. Obviously, we can take that kind of patient. My personal policy is I don't write opioids across state lines, so I try and keep everything in New York. It's been an issue for some of the people that got stuck in Florida with the COVID and couldn't get back to New York. But I would recommend if you are going to do an opioid, keep it within your state. Jen Kirschenbaum brought up a question online here about, med mal and liability for telemed. My understanding is we are covered, but I would try and keep it geographically within your reach as much as reasonable. And then if you want to be an expert on something where you just weigh in, then market yourself out of state. But I would advise against writing opioids out of state.
The next question we have is, I think, for Dr. Garibo again. How are prescription for DEA Schedule 2 substances to be handled? DEA said in-person visits are required for. So I think, yeah, why don't you go ahead and answer this question, please?
Can you repeat that question, please, Sudhir?
Yeah, there is a lot of disturbances. Sorry for that. How are the prescription for DEA Schedule 2 substances to be handled?
Sure. I mean, the New York State regulation is such that as per their requirements, at least from a documentation standpoint, each refill, each monthly prescription needs to be at the level of supported by an E&M visit type of documentation, including documentation of a physical exam. Now, I think like Ed said, the context is very important here. But for Schedule 2, there needs to be a biopsychosocial indication reset on a monthly basis with a history, a physical exam that used to be a hands-on physical exam that no longer needs to be hands-on through telemedicine and a combination, complementary, multidisciplinary plan of care. And I don't think that bar has been lowered. And I do think that telemedicine, as long as it's within the CDC guidelines, can be performed for such refills, but for anything beyond an in-person visit is preferred.
So a follow-up to this question, is there any limitations on telemedicine?
I think there are a lot of limitations. I mean, if somebody is needing an acute interventional technique, if somebody is on high-risk chronic opioid pharmacotherapy, and somehow, let's say we have them on a Dilaudid 8 or oxycodone 20 or Subsys 800, I don't think it may be an appropriate treatment. It needs to be documented very strongly, but I don't think that patient is an appropriate patient for telemedicine.
Okay, good answer. So next question is for Jessica. Now, we know that this is the situation currently we are going through is not going to change drastically. We are not going to go to normal as soon as everything is over. There would be a phase for months where we will be very slow to go back to normal. In that situation, what do you recommend? Should we have a simple telemedicine procedure, or should we go for more robust one?
Yeah, that's a great question. So most doctors already have an EHR for clinical documentation, prescribing, billing, etc., and they don't really want redundancy in those areas with a telemedicine platform, or completely change the workflow of your process at the office. So lightweight tools are also popular because they're easy and intuitive for the patient experience. And training staff to use complicated new tools is especially hard when everyone is remote. So I would recommend that you're using something that's HIPAA compliant, simple, and something that doesn't completely change the workflow of the processes you have in place currently.
Very good. Thank you so much. We now don't have any more questions, but they are still keep coming. So thank you, panel. Thank you, Chris, Ed, and Jessica. You guys wonderful, and we appreciate it. But please stay standby, because as questions come, I might come back to you guys. So now it's time to move on to the second panel. The second panel is focused on the CARES Act and Medicare program of the advanced and accelerated payments. We have excellent speakers, Dr. Chapman, Dr. Durkin, and Jennifer Kirschenbaum, who is a very renowned expert in our area. She's also a regular speaker at our New York, New Jersey Pain Symposium. And she, as far as I know, she helps to almost all my colleagues who are practicing in this area. So we are very happy that Jennifer is with us. I'll start introducing the first speaker, Ken Chapman. Dr. Chapman is the president-elect of New York, New Jersey Pain Symposium. He has a very, very busy practice. He has almost more than 60 staff. I don't know how he manages all this in this situation, but he's very busy. He has multiple offices, and he is going to speak on the CARES Act, and then follow-up would be Brian Durkin. So Dr. Chapman, please take over.
Thank you, Dr. Dewan. Can we move on to the next slide, please? So I spoke last week on the CARES Act and kind of gave an overview of where it stood and what our interpretation of it was at that time. And Jennifer, who was going to be on last year, is going to give us an update as far as where we stand with it. But as you recall, CARES Act is $350 billion that was appropriated by Congress to help small business. Excuse me, this is the PPP part of the CARES Act, which is a $2.2 trillion dollars that was put aside. So essentially, the PPP is meant payroll protection program as a support for small businesses to pay their employees. You know, the problem and the problems that we've experienced so far, though, is that already as of 3 days ago, almost $125 billion of that $350 billion has already been appropriated. And unfortunately, many people have not even been able to submit their applications yet. So this is very, very worrisome. Our group, which is going to be very dependent on getting and receiving this money, was just able to submit our applications yesterday at yesterday afternoon. And there's really not that much. We're all sort of helpless as far as to whether the banks are going to accept them and submit them for us. So that being said, they're trying to pass another stage of the assistance, which would be another $250 billion. But that is currently held up in Congress, and it's very unfortunate because this has already been delayed a week with the first holdup, and now we're holding up another week. And this can be catastrophic for a lot of businesses, not just medical practices across the United States. Next slide, please. So I don't know if any of you guys noticed, you may have woken up yesterday and looked in your practice bank account and noticed there was more money in it. And so within the CARES Act was also the Provider Relief Fund. And essentially it was $100 billion set aside for hospitals and healthcare providers from HHS, which is Medicare. And this is money that does not need to be repaid. There's I can't tell you yet if it is a grant or a payment. The wording on the released paperwork from HSS is that it is a payment, which in some ways makes sense to me, but let me go on first. They released 30 billion of that on Friday. And so providers or providers within a practice, essentially what they did is they took a portion, they took the total amount that's spent by Medicare annually, or all of 2019, which is $484 billion. And essentially you take what you were going to collect from Medicare over that time. And so you would, to kind of estimate what the amount of money you get, is you take your 219 Medicare fee for service, so that's what FFS stands for. So not including Advantage plans, what you collected from Medicare, all right, or your practice, I should say, or you personally, if you're a solo practitioner, you divide that number by 484 billion, which is the total amount spent, and then you're going to multiply it by 30 billion. And so to do that and to make it kind of tangible, and you can see on that bottom line, so if you collected $100,000 divided by 484 billion times 30 billion is $6,198. So you can pretty much just multiply, the amount of what you got by 6,000 if it's closest to a 100,000 number. All right, this is another, there's a couple other good things coming out of this. This is not really related to us. It's anything related to COVID. The health insurances are going to waive any co-pays, deductibles, or anything of those natures, and they're going to make sure the hospitals are getting paid so that patients are not going to be stuck with bills from this. There are other good things. They're trying to fight to get the business interruption covered by insurance. I know in New Jersey, I heard there's legal cases going on, and I've been receiving emails as well as far as litigation to get business interruption covered. Next slide, please. So, people, I think the natural instinct when people hear that there's some sort of bailout for small businesses is that it's going to be a windfall for practices or any business. But the reality is really not. And here's not saying it's not, and it's great, and it's greatly needed and appreciated, but here's an example of what, say, your typical small practice would kind of face, right? So with that many staff on the left there, you could look at their salaries, and we're going to multiply the salaries by how many there are, right? And their total salary of a practice this size would be about $1.6 million. That being said, anything over $100,000 isn't going to be covered. So that 1.6, the amount that you're available for with the CARES Act would be $1,015,000, right? And then so you're going to prorate that for 12 months, and that's going to be $84,583, and it's 2.5 is the multiple that you're going to multiply the monthly payroll by. So this practice would be able to receive $211,000 and 458. So with this practice, with their actual payroll though is 141,000 if you were to divide the total salaries by 12. Okay, which still sounds pretty good, but let's turn to the next slide. So if you add your taxes, et cetera, onto your payroll, that's going to be about your monthly payroll is going to be about $150,000. And what your payroll is to your overall overhead is different for everybody. For us, it's about 50 to 60%. So if we were to say that if our payroll is 150,000 and it's 50% of our overhead is $300,000 a month. So then if you subtract that by what you get from the CARES Act, you're left with $88,542. And so there's really not enough to really get you through a month if you really don't have any income coming in. And also the challenges too, as well, are going to be getting the employees to come back that have left, because that money has to be spent on your payroll has to stay the same from before and after this whole event. And so that's also coupled with the fact that our income is going to be drastically reduced because, we're probably mostly seeing follow-ups, a sporadic new patient here or there. And the reality is maybe 25% of our income is going to be coming in from follow-ups only. So we have we're really in the hole here. So what can we do to stay afloat during this time or to keep viable? Essentially, we have to contract a little bit. Discuss with people that or payments that need to be made. If you can delay the payments, you can speak to landlords as far as a rent reduction or delay in payment of those. The question is malpractice something that can be written off in the previous or can be put on hold or put to part-time? I believe that I'm aware of physicians that have discussed it with malpractice Milmic, and they were able to reduce if they went down to part-time. Obviously, we have to, everyone would have to decrease their overhead, meaning furlough or release employees. And a very sensitive subject is the physician salaries, because, everybody's worked very hard and to have, because of that big responsibility of paying that money, almost every practice that I know has had the physicians have taken pay cuts, and it's a difficult thing, but it's something that nobody wants, and is when we get through this, hopefully everybody will be able to bounce back and look back and be proud of ourselves in the way we handled everything. Next slide. Is that it? All right.
Is this your last slide or this is Brian's slides?
Brian's.
Right. Okay. So the next speaker is Dr. Durkin, and he will speak on Accelerated Advance Payment Program. Dr. Durkin is our current president of NYSIPP. He is also a very regular speaker at our New York, New Jersey Pain Symposium. He has multiple practices in Long Island, and he's very knowledgeable in this very complicated and poorly understood subject. So looking forward to listening to his talk. Take over, Brian.
Thank you, Dr. Dewan. So I'm going to talk about the Accelerated Payment Program for Medicare providers, which is actually nothing new. It's just been really expanded over this last month now. So this program has been in place for if you're in the hurricane zone of the country and a hurricane comes through and knocks out your practice, this system has been set in place for practices in those small parts of the country. And what it does is it's basically a short-term loan with no interest. And currently, it's been expanded to cover everybody now in the country due to the coronavirus pandemic. So if we look at who's eligible, everybody in healthcare is essentially eligible to participate if you take Medicare. So Part A are the hospitals, Part B are the physicians and suppliers and other providers such as physical therapists, et cetera. So if you're a Part B provider, like most people probably watching today, you're eligible for this program. You just have to be a participant of Medicare within the last 6 months, meaning you've taken Medicare and billed for them. And what you do, and you have to be in good standing, essentially not have any bankruptcy or been accused of any Medicare fraud in the past. So that's who's eligible, which is I'm sure everybody here that's watching. The payment, like I said, is a loan, and you can get at this time 100%. It's been increased since the pandemic began. Previously, I believe it was 75% of what you collected from Medicare over a prior 3-month period. So if you go back to December, January, February, and take that money that you were paid by Medicare through your usual practice, that's what you can now get paid up front, with the idea that you will pay that back in the future, in the near future. So if, for example, you billed Medicare $50,000 in that time frame, you can now get a check from Medicare for $50,000 to help bridge your current situation. They have done very well. I've heard reports that people have gotten this done, gotten payment within 3 or 4 days. Processing time on paper from Medicare CMS is that they're going to do this within 7 days or less. So you get your payment. Now, when do you got to pay it back? That's the question. The current standard now, the law is it begins 120 days after the check has been dispersed. So you've got 4 months of a bridge before you start paying it back. And how do you pay it back is when you submit claims 4 months from now to Medicare, instead of them paying you back, paying your claim submission, they just put that against your loan. So it's a nice way to spread out your payments over the next 6 months or so. You have 210 days to repay that loan, and currently our NYSIPP lobbyists are trying to get this advanced to a longer repayment time, and perhaps even more than 3 months into maybe a 6-month amount of money you can get. We'll just see how the current pandemic plays out. So the way to do it is pretty simple. You contact your Medicare administrative contractor, your MAC. For us in the tri-state area, that's National Government Services, or NGS. And that's the phone number that you can call. You can Google this accelerated payment program for Medicare providers. There's a link. There's a form you fill out and send it in, and hopefully within a week you can get some cash if you are strapped currently. So that's a nice thing for Medicare to help us get a short-term loan without a lot of red tape involved. And that's it.
Thank you, Brian. This is very educational, very informative, and we have a lot of questions coming in, so we will address all the questions after Jennifer's presentation. So Jennifer is our backup expert for all questions, and as I said, she's very she's expert. She knows up-to-date information, so hopefully we will have most of the questions answered by her. She is counsel to the New York, New Jersey Interventional Pain Symposium. She's a managing partner of Kirschenbaum and Kirschenbaum Healthcare Department, and represents ASCs and physicians with contracts, compliance, and patient and employee issues in this area. As I said before, she is the advisor to almost all my physicians that I practice in this area. So she's very highly respected and reputed lawyer in this area. So with that, I would ask Jennifer to take over.
Thank you, Dr. Dewan. I'm here to bat cleanup. We're only going to spend a few minutes on information and then we can flip over to questions. I do not have to treat patients or know anything about patient care, so I get to spend my time on everything else. Quick summary, I know we've spent a lot of time on the CARES Act the last week or so, so just for some of us who are just getting caught up, I'm just going to spend just 2 or 3 slides on it and then we'll get to questions. But I think we all understand that the EDL grant was available, made available. Many of us have not received funding on it, but for $10,000 is an overhead replacement loan or grant. And on your PPP application, there was a location at the top that asked you if you received this money yet or if you applied for this money. And the reason why is that the government is not going to allow you to take 2 bites of an apple here for any of the benefits really that they're offering. So you had to let them know in your PPP application if you anticipated receiving the grant money, because they're not going to allow that number to be forgiven in addition. So I wanted to make sure we referenced it here and establish expectation. The forgivable loan portion that we're all hoping to get, and I think Dr. Chapman gave a great overview of it on where we stand now. For many people, that's at a standstill. Either their banks have not processed or have not submitted to SBA yet, or if they have submitted to SBA, the money has not been funded. I do know of a few practices that have received funding. So funds are flowing, and hopefully there will be more activity this coming week. And hopefully many of us on the line who have submitted applications will receive funding before the funds do dry out, which I anticipate will happen within the next probably week or 2. As we know, Congress is going to be waiting to re-up on that amount, the $250 that they're going to be trying to reload. So what we submitted for, and I hope this is the case, and if you have not finalized your application, it's going to be payroll expenses that you have with a cap at $100,000 per high earning individual. So the way that I'm looking at it is that I know there's a lot of misinformation and different interpretations of this law. I'm not going to spend a lot of time going through all of it, but the $100,000 cap in my mind is a cap. So don't do $100,000 annualized for yourself plus your portion of the health insurance that you would be contributing normally for yourself. It's a cap. So put the $8,333 total for the month, and then you're going to multiply the numbers that you have for payroll costs times 2.5, and that's going to be the number that you're entitled to for the loan, which Dr. Chapman went through. Another point that I want to go through, because I'm not sure if it's been covered before, but the federal supplement for unemployment has started rolling out, and for everyone who has been laid off that is in the unemployment system, they will be receiving an additional $600 per week. Now, for some of you who've heard me speak on any of this stuff the last couple of weeks, I was assuming that the state was going to lower their maximum so that way our employees would not potentially be getting more money on unemployment than they would if they were working, because obviously that's kind of a perverse incentive. So far, that adjustment has not been made. So if you have an individual who makes $38,000 a year annualized, if they are getting what they're entitled to under New York State, plus the straight up $600 stipend from the federal government, which is how it's being paid, there is a potential that they could be making more money on unemployment than they would working. So it's going to be interesting how that plays out. Now, to qualify for unemployment, you need to be actively looking for work. So if you as the employer are seeking for them to come back and they say, no, thank you, I'm going to sit at home and remain on unemployment, they would not be eligible for those continued payments. However, I'm not sure how the government is going to actually track and address that. So how do you get this money? You've applied for the PPP. You're going to go through your banking institution. You cannot go direct, so you're going to have to wait. You should know that, again, you're in the same boat as most of your colleagues. Most applications have not been processed to date. BAML got a quick jump on it, and they have some that have been processed. So this is my final slide, I think. Once everyone receives their funding, which I'm not guaranteeing, But if you do receive your funding, what are you allowed to use it for? And then we can go through some questions. You're going to use 75% of those funds towards payroll. And that's going to include salaries for employees, health care benefits. You can use severance, additional bonus compensation. Some of our doctors are paid on production if they're not working right now, but you owe them a quarterly payment. I believe that we would be able to apply their up to their $8,333 amount that you can spend on them towards a production payment that might be owed for incentive compensation during this time period. Now, to be clear, you only have 8 weeks to spend the money from when you get it. So you're able to use it for payroll costs and some of the extra stuff we're going to talk about. 25% can go to rent and utilities and interest and other debt obligations. You have to spend it within an 8-week period from when you receive it, and that is going to be your covered period for potential forgiveness. Anything that you have left over after the 8-week period that you spend, or anything you spend outside of these categories or outside of the percentage allocation you're allowed to use, will convert into a regular loan construct that is going to be a 2-year loan for maturity, and it'll be at 1% interest. So it's not the end of the world if you do have a remainder or if you don't meet all the categories, because it's not going to be that expensive of a loan. It's going to be the cheapest money you probably can get out there. And for many of us, capitalization is king and key right now. So, but just be very, very mindful of how you can use the funds. And if we're going to go through questions now to hopefully make things easier. The forgiveness decision is not clear when you would apply, but my best guess is it's going to be well after the covered period is complete. So it'll be after the 8-week period, and I'm guessing sometime later in the summer or fall. So you're going to be waiting a while to find out if the money that you've spent is actually going to be forgiven. But your bank, who's going to be making the decision about forgiveness, is going to be handcuffed by the provisions of the law. And it's pretty particular that if you follow these allowed uses, you should qualify for forgiveness. We're going to document everything very carefully during this period of time. Go to the next slide.
Okay, looks like this is your last slide. So thank you so much, Jennifer. This was very, very helpful, very educational and informative. But what that means is we have many, many questions. So let me start the questions as these still keep coming. One question we have is how long should it take before they grant? Somebody applied for April 1st and still there is no answer.
The best I think that any of us can answer is you really have to follow up with your bank and try to elevate because it's going to be first come, first serve. And I don't have any additional information on whether or not, for instance, Bank of America is going to get 100% of this money because they've gotten everyone in first, or if the government will say, no, slow down, we're going to start saving money for community banks. SBA is going to, they've already been shrouded in the secrecy. They're not giving a lot of information out on how they're processing or what they're processing. So they may actually start cherry picking, or they might just go straight with first come, first serve. I have no idea. So
next question is very, very broad, but I'm going to ask you in pieces. So for example, we have the limit of 100,000. I have no idea why government did not think that, no physician works in 100,000. So how can you really do a payroll protection with a cap of 100,000? What that means is the physician who is on salary has to have lower pay. How can we do that?
Okay, so there's a couple of things here. So the Paycheck Protection Act is to try to take individuals off of the unemployment system. That was the public policy standpoint on it. So it was less to serve as replacement revenue for owners. It was more to protect against the construct of the unemployment system, so that way when we can get back to work, we can do so fairly seamlessly, and our employees are still on our payroll. So that's why they did paycheck replacement. Now, if you're following in New York State and other places, business interruption insurance, which is typically the mechanism that is utilized to replace a revenue stream or lost revenue for businesses. There's legislation coming through in different states. New York has a proposed bill looking to force insurers to replace our lost revenue during this time, if you have that insurance. There's also lawsuits that have been filed. Thomas Keller filed a very public lawsuit against his insurance company. He's not the only one. There's been a slew of litigation. This time period is going to be legislated and litigated and audited for the next decade to come. I can guarantee you that my litigation colleagues are going to be very, very, very busy. So the answer to the aggrieved employer of what am I supposed to do, you know, my quality of life and my expenses and my family and the decisions that I've made to this point rely on an income stream, and this is not an income replacement for me. 100%, I hear you, and that was not the intention of this law. And so we have to look to other areas of relief for that revenue stream. And again, I'm sitting in the same boat as everybody else for our law firm too. You know, I have no idea how this is going to shake out. I was talking with a panel yesterday about it, and if the business interruption legislation comes through, or if we start winning these lawsuits on it, you know, the next bailout is going to be for Lloyd's of London, because the insurance industry is going to go down. So we're going to see how the government wants this time frame to be covered. And it's an interesting thing because it's not the pandemic that really is closing us down. It's the government executive orders that are stipulating what is emergency care, which is a different conversation than is it prudent from a medical standpoint for us to be exposing our staff and our patients to our offices right now. This is a whole nother didactic we could be having on this.
Would a physician be qualified for unemployment collections?
An employed physician, yes. An owner of a corporate entity, an S Corp or C Corp, while that entity is in existence, has not been dissolved, in New York State will not qualify for unemployment. I can't speak to other states.
So my question was for those who are employed. If I cannot pay them 100% of their salary and I put them 40%, and then can they qualify for 60% of their unemployment?
They may be still making too much money to qualify for unemployment in that circumstance, but your employed physicians that are not working right now or are working only on telemedicine and making only a couple of hours a week worth of money, or 100% they should be on unemployment right now. Because while they may feel that it's stigmatized and they never in their life thought that they would be on the unemployment line, the annualized salary that they'll be collecting, at least for New York State, is about $55,000 a year. It's better than nothing, and they 100% should get in line and take the additional federal supplement. And then once they can start working again, or if they start working part-time, it's their obligation to report to unemployment the income that they've received for that particular week, and they may be subject to a reduction or they may not.
All right. The next question is for Dr. Durkin. The Medicare Accelerated Advance Program gives you 3 months 100%. As you know, NYSIPP is working on increasing that amount. They are asking, NYSIPP is asking for either 125% for 3 months or 100% for 6 months. Any updates on that?
No, I think that'd be great. You know, hopefully this pandemic doesn't last that long and we can get back to doing our usual thing. But it, you know, more I think is better in any scenario. And if we can get more, I think most practices will be able to sustain this hit for the next several months, if that's going to be what we're going to be stuck with. So the answer is to get back to work. If we can't go back to work, increasing the amount that we can take from the future from Medicare, I think will make things a lot smoother for us now, and then spread out the loss over the next 6 months as opposed to the next 2 months.
Excellent. Ken, this is a question for you. Do you health insurance benefit fall within the 75% of payroll expenses?
That I believe that it does fall. It does fall within it. group health insurance is a category in there, and Jennifer would be able to confirm that most likely.
Yeah, Jennifer, can you chip in?
Yes, the doctor's correct.
Okay, excellent. Yeah. So now, Ken, didn't mean to really put you on the spot, but how are you handling? How are you discussing this less page, to your employee doctors, and how are they taking?
Well, I would like to say that everybody that we've dealt with our practices has been very understanding and willing to do whatever they can to help. So from our rental properties to payers to our doctors, and they've been great about it. And it was almost without hesitation that they agreed to it. I mean, the scary part is how do you put a timeline on this? And it's really challenging times. But the doctors, all of our doctors, have been very good about it. But we just really need to figure out how we get everything back to normal.
I must agree with you. I have also a few friends that I have talked to them, and it's really all the physicians are, understanding the situation, because we are all in this together. It's not, that you are doing somebody to give less money, and understanding from your employee and your physician partners is very, very important, in this situation. Jennifer, does a sole proprietor company with only the physician and no real employees qualify for PPP?
Yes, and yes, they'll qualify. And if it's depending on how, and independent contractors qualify as well. They were able to start filing as of yesterday. If you do not get the PPP money and you're a sole proprietor, you also may qualify for unemployment. However, the PPP will likely be more money for you. Your unemployment, again, would probably be tapping out around a $55,000 a year annualized salary, whereas the PPP would be $100,000 annualized if you have the support from prior year.
The next question is very interesting. The employer has 5 employees on H-1 visa. How unemployment rules and unemployment laws will apply to them?
So I have to say I'm not an immigration specialist. I'm going to have to punt this one. I can certainly get some more information and email Dr. Dewan after the fact. If any of the doctors happen to know how this works, I'm happy to kick it to them.
I remember seeing that you had to be an American citizen to get the money.
For the PPP.
Yeah. The application I filled out also said that I had to verify that all my employees were U.S. citizens. So that was a question on my application.
I'm just not sure for unemployment. That one, I don't know.
Okay. There is another one question. So in doctors' offices, we will not see the impact of not doing injections. New patient, etc., won't be seen till June or July. So we have started salary reduction now, even though we won't have collections issues for another 6 to 8 weeks. Is there how collections are delayed 4 to 10 weeks after providing the services? Did you understand the question? Should I read it again?
What was the question part?
Yeah, that was the question. So we will not see the impact of not doing injection. New patient, etc., won't be seen until June and July. So we won't have a collection issues another 4 to 6 weeks. How collections are delayed 4 to 10 weeks after providing the services?
This is an AR question, so possibly Dr. Durkin, if you want to go over maybe Medicare accelerated payment again, if this provider is a Medicare provider, then in this instance that might be a solution to help with cash flow. It's a cash flow problem.
Absolutely. If you are a Medicare provider, you have an opportunity to get a good chunk of change right now within 7 days. And Medicare has made a commitment to give you the money within 7 days. And the reports I've heard are people are getting it in 3 or 4 days. So, if you get on the website, fill out the form, you're a good doctor and you haven't done anything wrong, Medicare will give you the money that you would have made if this pandemic did not occur, and then you just pay it off later down the road. So what the
Sorry, we lost the connection.
Okay.
Yes, it sounds like we lost Dr. Durkin.
Okay. So yeah, the money, he was just explaining that the money that is going to be fronted is going to have to be recouped at some point from Medicare. So it's basically like you're borrowing from Paul to pay Tom, and then later you're going to have to repay Paul. But at that point, hopefully you would be back up and running and your commercial payers would be paying and you would have a little bit less of a cash crisis. The business interruption insurance conversation that I referenced before also would come into play here. If we could possibly see some recovery there, that's where you're going to see more assistance if you have that policy, which is, we'll see how that's going to shake out. So everyone's going to be down basically a full quarter. That's pretty much every business owner. I know telemedicine is not going to make a massive change for many of you during this time period. So we have to use the avenues that are available.
The next question seems to be a little confusing to me, but I'm going to read. The understanding is that you can take EIDL loan and a PPP loan, and that the EIDL loan will be rolled into a PPP loan.
That's correct. So you can get the grant. Well, there's different. That's a complicated question because the PPP is under SBA Section 7A. That's one way you can get a loan is under the law 7A under the SBA laws. The EDL disaster loan is another loan construct that's a low interest loan that's under Section 7B. So if you went for an EDL loan, not just a $10,000 grant, that's a more complicated issue. The EDL grant, which if you signed up for that free $10,000, no strings attached grant, promised to use towards your overhead, that $10,000 can be rolled into the PPP loan, no problem. So that's fine. It's just going to be, so the roll in, just to confuse everyone a little bit more, is if you got the $10,000 under the grant because you requested it, and then you get your PPP loan, let's say you asked for $100,000 for the PPP loan, you're not going to be able to get $110,000 forgiven because you got the grant, no strings attached, for $10,000. So your forgivable amount, even though it's going to be paid at the same time, will only be $100,000 for the PPP. It's not going to be 110 because you received the 110 at the same time. You can't double dip. You can't get a grant, no strings attached, plus also receive forgiveness credit for that.
Thank you. Jennifer, you have so many questions just for you, and these guys, I have no questions. So we will just keep listening to you. Another question is, can a company reduce the salary of a physician by 50% or employees at all, or minimum to 10 to 20%? Is that legal?
So you're asking if you can, there's a couple of different things. Can you treat different classes of employees differently? Can you treat the staff different than you treat the physicians? Can you treat the physicians different than you treat the nurse practitioners or the PAs? The answer is yes. You can treat different situated staff differently. That's okay. The physicians, many of us have contracted, and if Dr. Chapman wants to comment on what he thinks is good, I'm happy to pause for him to do so. I'll give a little information first, which is that if we have a contract with a doctor, many of our contracts read that we have to give the doctor 30, 60, or 90 days notice before we can terminate them. if you are asking a doctor to take a 50% cut, you will potentially be, or you would be, in breach of your contractual relationship with that employed physician. So the way that you would have to do it in my mind is you would have to speak with them and have them agree to a reduced salary during this time. And you would want it memorialized in a writing. So that way they do not have leverage over you later that you have been in breach of this contractual obligation. It gets very sticky. Most human beings will not fight on this right now. They'll be reasonable depending on how you present it. Just so I can just give an example of what some larger groups are doing, so you understand that if you approach this the right way with the right narrative to your employees, I've seen great success from most of my clients. But NRAD, who I do not represent, and I can just state what they did, they sent out amendments to all of their radiologists. And the amendment said, you can sign this or you're terminated. You're going to work a lower percentage of amount of time you normally would, and you are going to be paid, I think it was about 50% of what your stated compensation is in your contract. And you have 3 days to get this back to us. And that was a contractual amendment that they sent out to everybody and said, sign it or you're fired. If for the doctors who don't sign it, they will be entitled to their salary during the notice period under the contract. For those who do sign it, there was no end date to when this comp adjustment would end. NRAD basically said that they would make the determination when their finances supported a readjustment back to the physician's salary, which is a nightmare because the government could lift and we could be back to work, and they could just say that, look, because of the financial burden that this has put on us, we are not going to restore physician salaries. So it's a very, very tricky position. That's pretty much a worst case that I've seen. Most of my practices, and again, if anyone wants to speak up, I think it would be helpful for your colleagues to hear from you, have created a very positive narrative that we're all in the same boat. If we are put into a dearth of capitalization position, we're gonna have a very difficult time reopening. Please work with me so I can help you so we can open back up later. And this is really what I need from you. And can we agree during this time on this? And that's how they've kind of stated it for the employed physicians.
And the next question is, what if your employee, whether physician or staff, do not agree to take cuts in the salary? Can you fire them?
You would have to terminate in accordance with what your agreement is with that particular employee. So if it's someone who is an at-will employee, you can terminate them on the spot. If it's someone who has a contract with you, you're going to have to follow the contractual provisions, or when this is over, you're going to find yourself potentially in the till of litigation for a claim of breach of contract, and you may have monies that are owed to that employee.
Wonderful. Now this next question is for Dr. Rubin. Can you clarify on the co-payments on telemedicine?
Yes, so let's see if I can come back up on video. The answer is they were only waiving copays for COVID-related treatment. And typically in a pain management situation, it's got nothing to do with COVID. So I feel that copays are still due. That's what it says on the CMS website, that the normal copays would still apply. I know a lot of patients are going to say, well, I heard that copays were waived and this and that, but that's only specific to COVID, not the treatments that we're offering.
And the other question is very similar. If you do have out-of-state patients coming for the prescription, does it have any impact on your malpractice career?
I don't, Jen, do you know anything legally on that front specifically? I mean, my understanding is that you're still covered. I mean, you have an existing physician-patient relationship. I would advise people against taking out-of-state patients sight unseen for opioids. But have I, with existing patients who I know personally that got stuck in Florida during this, send them a script to Florida? Yeah. But again, it goes to context. Like, if you have no problem with it being on the cover of tomorrow's, Newsday, then probably that's a good litmus test. This 85-year-old lady who I've been treating for years is stuck in Florida. I sent her a script. If somebody just cold called your office and said, I'll pay $400 for a script, I mean, that's not reasonable. So I think the context matters and how you're doing it. As a general rule, I try and advise against writing out of state unless it's really necessary.
I think what I want to add to that, and look, for those of you who I do work with on a regular basis, I think that whenever you call me with a problem with a payer for audit or whatever, I tell you it's the last thing I want to work on with you, and that's the truth, except possibly an OPMC matter, which is even worse. I think, it's easy to hear all the messages that are being given to the healthcare community right now of everything is relaxed, we need you, please step up, please, just treat however you can. And I think it's easy for us to say, okay, well, we can be comfortable and during this time. Please don't hear that message that way, because there's going to be a slew of audit after this is over. And I want you to be really paranoid. The prescription monitoring program must be checked before you write any Schedule II or anything else you think is appropriate. It should be, for check for that. Please document everything. Please be really, really, really vigilant, because I can tell you that one place that's going to be hiring like crazy when this is over is going to be the government, and they're going to be hiring for auditing in all types of capacities, whether it's going to be for Medicare funds paid out or for this PPP program we're talking about now. So please, check with your malpractice carrier. Some of them are trying to disclaim certain COVID services. I've heard that come up, which is disgusting. I'm assuming not the main ones in New York State. They're not going to get away with that, but you might have an RRG that's looking to carve out certain things. So just check, be vigilant, do your best practices now, try, even on the HIPAA stuff, try to be really careful on how you're going to administer the telehealth and prescribing.
Very good. So our next question is for any one of you. If an ASC staffs through a third-party professional employer organization, staffing company, can ASC still apply for PPP?
So I think I can answer that. The ASC can apply for PPP, as well as they would get the money from HSS for the depending on how much they receive from Medicare in the past. So they count as a practice and as a provider as well.
Excellent. The next question is for Chris, Dr. Garibo. Now, what type of telemedicine visit may create circumstances that you want to schedule patient for procedure?
There are many situations that are not appropriate to schedule a procedure in the current environment. So I just want to raise the concern that there's truly a very high bar right now for scheduling interventional pain management. You need to demonstrate thorough failure of conservative management. You need to document decreasing function, inability to take care of themselves, and just not doing well and not be able to survive in the current COVID crisis environment. And it's something that they truly essentially need to be able to take care of themselves at a fundamental level. I had multiple situations as somebody in a primarily interventional practice where I gave them opioids when I normally don't. I put them on PO steroids, and I used telemedicine to document that thoroughly. And there's one patient, for example, I'm probably going to go in on Monday to inject them. So we don't want to create a situation where, as Jennifer was saying, we're getting audited afterwards for inappropriate utilization at time of the COVID crisis.
The next question is for Jessica. We did have telemedicine before this COVID-19 crisis. Now, how has it changed, or how the COVID-19 has impacted the practice of telemedicine.
So telemedicine features haven't changed much outside of regulations being a little bit more relaxed. With that said, there are other telemedicine platforms that have become more robust as well, adding billing and different features like that, which are pretty new. But in terms of what's going on now with COVID, there's just a lot more awareness for patients right now, and it's the only way that they can technically communicate with their physicians. So adoption rate in terms of telemedicine was pretty low prior. I would say the biggest change is that the adoption will increase, and patients will likely get used to this experience, and there's a chance they may not want to go back to traditional in-office visits. So I would say more patient adoption, creating more demand is really the biggest focus when it comes to that question.
I'd like to chime in on that too. I think we're going to hit some sort of intermediate normal where I foresee trying to keep the telemed going for some of the stable script refills, really just to reduce the density of people in the office. So if you can get half of those human beings to not physically be there, because even if they do open things up in 2 or 3 months, like it's not going to be back to normal for the better part of a year. So you want to keep your office numbers down without losing the revenue. So I would say the future is, half telemed for stable, and then bring in the people that need the physical exams and the interventions.
The last question is for Chris. For opioid refills, does it really matter that you have to have 15 minutes, or you can have 2 minutes quick follow-up and it can still consider it as a visit?
I think it's important to raise the bar as much as you can within the context of a telemedicine visit, and do what you can through that telemedicine visit. I'm not sure if 2 minutes is enough, and a lot of this depends on what's being prescribed. If somebody's simply getting Tylenol number 3, 60 pills a month, that can be a couple of minutes. But we've got to document that physical exam. It can be a simplistic physical exam, and I think your documentation needs to be linearly correlating with how complex your opioid prescribing is. The more complex it is, the more thorough and in-person it needs to be. If you're within the CDC guidelines, you can be within, you can do telemedicine, but within the higher end, you just got to document more thoroughly, including having a greater duration for that visit.
Thank you very much. We are way over the time, and I would like to take this time to thank you, our all panelists. You guys are wonderful, outstanding discussion. And Jessica, Jennifer, you guys wonderful. So I personally thank everybody to take this time and make this webinar very successful. I would also like to thank our organizers, especially Michelle and Sandra. You guys are really fantastic in marketing and making the banners and reaching out to all of us. It was really wonderful. And again, I would like to thank Jessica, especially for sponsoring this program, also giving your expertise, help, and thank you very, very much.
Thank you.
At this point, I want to take a pause and give a big shout out to our healthcare workers who are really putting their life at risk and working very hard on the front line. It's just unbelievable work they do. There are no words we can thank them to thank them for their heroic work that they are doing. So that only thing we can do that everybody out there, whether you are a physician, you are nurse, physicians, or nurse practitioner, or the support staff who help the frontline workers, we thank you from bottom of our heart. We will always praying for your safety. God will help you. God has to help you, and God bless you. I wish everybody happy Easter and happy Passover. And this is the end of our webinar. Thank you, everybody.
Thank you.
Yep.